Welcome to the Complex PCI 2020 virtual. I'm Yangsoo from Seoul, Korea, Yonsei University, and my co-moderator is Dr. Kwok from Hong Kong. Welcome all of you. Let me introduce the panelists, Dr. Yoshihide Fujimoto from Narita, Japan, and Dr. Huang from Taiwan. Dr. Kwok, Kwok, will you start the first presentation introduction?
Yeah, the first case is a challenging case of CTO, how I managed by Dr. Satish Chirde from India. Dr. Chirde, please.
Yeah, this is the case of chronic total occlusion. This I have nothing to disclose. This is a 65-year female, non-hypertensive, non-diabetic. She presented with the inferior wall MI 1 year back. That time she was managed medically. There was no detailed history whether she was thrombolized that time. But again, she presented with angina and it was showing again inferior wall MI. She was thrombolized with the streptokinase at peripheral center and then was referred for the further evaluation, coronary angiography. So her blood investigations were normal. ECG she was showing evolved inferior wall MI. There was moderate LV dysfunction. Ejection fraction was around 35%. Did angiogram. Angiogram, it shows a proximal RCA total occlusion. So I decided to open this vessel and I chose a femoral access. 6 French femoral sheath, Cordis sheath was taken. Initially I took JR guide, try to engage, but I could not succeed. So I switch over to the 0.75 AL. I use cross-sheet run-through wire and few balloons. This was I crossed the lesion with cross-sheet 100. Stiff wire I took. I crossed the vessel and then I this dotted vessel with the 1.2 and 2.8 balloons. So I could see a little flow, but I was not sure whether this wire is subintimal or it is a thrombus. So I pre-dilated it multiple times with the 1.5 and 2.8 semi-compliant balloon. But I pre-dilated till the mid portion of the RCA, but I could see a very little flow. So I in spite of all this pre-dilatation, I was not able to see distal vessel completely. So then I decided to put Philolima eluting state 2.75/28. I implanted proximally, but still distal vessel I could not see. Again, I dotted this with the 1.5 and 2 balloon, but was not able to see the distal vessel. So I took 2.58 balloon. I could park this vessel till the bifurcation where I pre-dilated it with the higher pressure. Then I little I could see the distal vessel. So I was happy that I could see the distal vessel, and then I decided to put another 2.544 sirolimus seating state. That was an overlapping stent. I implanted it around the 12 atmosphere. So in the third picture, we can see the vessel is fully open and the results look good. So again, I took a 3x8 balloon, which was post-dilated from proximal to distal up to the various pressures, maximum 14 atmospheric pressure. I post-dilated, and this is the final result of the RCA total occlusion. Patient was hemodynamically stable throughout the procedure, and without any complication, I could manage this case. So what I feel, the CTOs are always a challenging case, but correct hardware like guide, wire can increase our success rate. The only challenge which I was facing in this case, I was not sure whether I am entering subintimally or it is a thrombus. But because the first stent show it's a good result, the distal vessel still was not visible. So with the multiple redilatation I could succeed. I put the second stent, and I think it was mostly a thrombus and not subintimal. So finally, the patience and our perseverance pay, and we can succeed in the cases.
Thank you, Dr. Chirde. Now it's open for discussion. Dr. Fujimoto, any comment on this case?
Yes, I'm Fujimoto. This case is, didn't you have IBUS catheter on this case?
Actually should have imaging, but see, we are working in the peripheral centers. We have limited resources, and so we are doing sometimes the cases in the this one government scheme. So we have very little resources. We have managed with whatever the fees. So on the clinical experience and this only I manage. I was
if you see IBUS, maybe your YY is in the true lumen, but some big dissection and hematoma is you can see. I think such hematoma covered second stent, also flow became good. I think so.
Yeah, quite agree. Another thing is, do you have any collateral from the left side? Because we only see the
yeah, I could not show, but very little distance means I will only PLV was feeling, not very means up to the mid portion, or very faintly I could see, but I did not take this collateral injection during this PCI.
Dr. Wong, any comment?
From my opinion, I think I don't have the ECG before intervention, and I think from your wire you go very easy. This is a truly chronic total occlusion or just a functional occlusion issue. And as you have one question about this is a thrombus or true chronic total occlusion, I think IBUS or OCT can have your good choice to decide this condition. Okay, this is my problem.
Do you, Dr. Shahis, do you meet any problem in terms of calcium during your procedure? Any calcification area?
No calcification.
So strictly speaking, this is actually, I mean, not that difficult, because if you have a high degree of calcification, then the whole thing may be totally different. But it's a very nice case.
I think maybe it's a long lesion. I could not see the distal vessel easily initially. I thought that one possibility, long lesion.
Yeah, but it seems your wire actually entering to a distal part quite well. So I'm sure that you are in the true lumen all the way along.
Yes.
So do we carry on to the next presenter?
Thank you everyone for the suggestion and comments.
Yeah. So next presenter is another interesting case, a complex high-risk PCI, the heart team approach by Michael Lucky Gergis from Egypt. So Michael?
Good day, everyone. My case today is entitled Complex High-Risk PCI, the Heart Team Approach. I'm Michael Gergis from Aswan Heart Center, Aswan, Egypt. I have nothing to disclose. So he was a 83-year-old gentleman. He is an ex-smoker, not diabetic, not hypertensive, was presented with high-risk non-ST elevation myocardial infarction with shooting troponin. His examination shows that he was in cardiogenic shock with bilateral fine crackles. His ECG showed diffuse ST depression in inferior and anterior leads, while his echo showed impaired LV systolic function at 30%. His coronary angiogram showed total occlusion of the right coronary artery with faint TIMI1 antegrade flow and retrograde filling from the left system. His left system shows left main bifurcation lesion, Medina 110, and the LED shows an ostial severe stenosis and another stenosis at the proximal segment as well. And you can appreciate here the retrograde swelling of the right system. On calculating the syntax score, his syntax score 1 was 23, and his syntax 2 recommendation is CABG or PCI. So we held a hard team discussion to discuss this case, and we had some problems that the patient was too frail, and he was originally from one of the minorities in the south of Egypt, and there is a language barrier because he is speaking one of the distinct languages. So the hard team decision was to go for PCI. However, there was some obstacles. That this is a complex PCI, unprotected left main with RCA total occlusion in a cardiogenic shock. So it is definitely preferred to be done on a mechanical circulatory support. However, Impella is not available in Egypt, and the 4 intra-aortic balloon pumps in our center were already busy on other patients. So the plan was to tackle RCA first. If failed, we can postpone PCI till secure an intra-aortic balloon pump or discuss the option of CABG again. And on PCI, we will do a provisional stenting strategy for the left system with a TAP technique as a bailout for the LCX. I made a bifemoral approach, Jatkin right and EBU 3.5. I could wire the RCA predilation with good flow, and then stenting post-dilation with this final result. Then we went to the left system, predilation and preparation of the left main lesions with compliant balloons, both balloons 2.5, 275 ruptured. So another predilation with an NC balloon 3x12 at high pressure, followed by PCI to the mid LED, 2.75 DES post-dilation, then PCI to the left main LED crossing over the LCX, flaring at the ostium with this result. As you can see here, the ostium of the LCX was pinched a little bit, so wires were recrossed after put at the left main, and after kissing balloon inflation at the LCX, unfortunately, heaviness was noticed at the LCX ostium, so we did the TAP PCI to the LCX, followed by kissing balloon inflation and final pot. Final IVUS runs showed a well-opposed stent with a minimal stent area at the LED of 7.5 and 10 millimeter square at the left main. As you can see here, this is a figure of 8 of the TAP PCI. This is a final shot after the IVUS run with a good result. My procedural time was 50 minutes. A radiation dose was 3 gray, and contrast volume was 300 cc. My take-home messages for this case that complex high-risk patients are not uncommon during the daily practice. Hard team discussion is considered a cornerstone in the management plan. Anatomical complexity reflected by syntax score is not the only parameter that judge the revascularization strategy, because some clinical and non-clinical factors that are not adequately reflected by score may favor PCI. And finally, the ability to achieve complete revascularization remains a key issue when choosing a revascularization strategy. Thank you very much.
Thank you. Now we're open for discussion. Dr. Huang, any comment on that?
From my personal opinion, this case is very difficult to do complete revascularization. Maybe if I have any discard during the PCI procedure, maybe we can perform a stage PCI. And after complete the RCA revascularization, we treat the left main and the circumflex. I think In the final IVAS image, maybe the stent maybe have another, didn't have a full open. Before procedure, before stent deployed, how to decide the stent size before the deploy stent?
Yes, I did an IVUS run before PCI to assess the vessel sizing, but I didn't choose the image here.
Yeah. Dr. Fujimoto, any comment?
In Japan, such a syntax maybe 23, in this case, it's all perform PCI, I think. This is a good case, I think.
For 83 years old lady, will you do cabbage?
Almost no in Japan. Really.
Back to PCI. Any comment on the case, Dr. J?
I think this is a tough case, but treated very well. I think very interesting case. Very good.
Actually, I mean, in any of the panelists or presenter here actually had impeller in your country. I think this case will be an ideal case for impeller support as well. Of course, I mean, Michael had managed to do it quite beautifully and smoothly without any impeller or any mechanical support. But in actual situation, I mean, in our centers, I think definitely will be a case with impeller support because in case anything went wrong, we still can manage to salvage the patient. So I think cases like that, I mean, unless you're really very precise and accurately knowing what you're doing, otherwise some mechanical support will be actually quite important. Sometimes you can do it under ECMO as well because I mean this is another alternative, but of course a lot higher complexity while doing the cases, but the safety will be actually a mandatory situation here. So can I go for the third presenter? PCI in a patient with non-operable severe CAD due to combined with severe bicuspid aortic stenosis by Wahyu from Indonesia. Wahyu.
Yeah, okay, thank you. I will bring my case PCI in patient with non-operable severe CAD due to recent ischemic stroke combined with severe bicuspid aortic stenosis. I have nothing to disclose. This is my case, male 84 years old with progressive angina every night and a recent stroke non-hemorrhagic June 20 and 20 and come to our hospital with severe aortic stenosis because of bicuspid valve and come to our hospital for aortic valve replace. The lab with higher kidney function with creatinine 1.5 and eGFR 42. The echo revealed ejection fraction 53% with bicuspid aortic valve with calcifications. Alpha is 0.5 centimeters square and gradients is 80 millimeters. This is the coronary angiography. Left main have a problem within the distal stenosis 60 to 70%, and then the distal of LCX subtotal and the proximal of LAD. And the RCA, we have a problems stenosis 70 to 80% in the mid part. This is our problems. 84 years old, octogenarian with progressive angina, severe aortic valve stenosis, significant CAD3 vessel and left main disease with recent stroke non-hemorrhagic with acute kidney injury and plan for long-term oral anticoagulant after surgery. We have 3 options treatment for these conditions. First is CABG and AVR, but the surgeon is refused to operate because increased risk of strokes because the stroke is less than 3 months. And then the third option is TAVI, but unfortunately the patient is unaffordable. And so we choose PCI, and then 2 months again, we going to do IV replacement. This is our strategy. We use stent appropriate for high bleeding risk patients with planning for dual antiplatelet only 1 month, followed with surgery 2 months later. Left main bifurcation stenting, we use 2 stent strategy. We use IFUS. For calcification, we use rota and scoring balloon, and we have to use low contrast. First, this is LCX preparations. We use balloon score flex 2.5 at the distal LCX, and then we use IFUS to evaluate LCX. Left main is 8.7, distal left main is 3.3, proximal LCX is the MLA 3.4, the distal LCX is 5.1. This is IFUS in the ALAD. The proximal is MLI is 4.2, the mid part is 4.7, and the distal is 3.9. This is LAD preparation. We use rotablator with bore 1.75. We try 5 times, and then after the bore can cross, we use balloon score flex 3.515 from the proximal to the distal, and then the LCX preparations. We use a balloon score flex 3.5 millimeter. Okay, and then we choose DK cross for PCI left main LAD and LCX. First, we PCI LCX 10, and then we complete cross in the LAD, and first recrossing to the distal strut, and then we done first kissing balloon, and then after that we PCI left main to LAD hybrid stent, and then we did pot in the left main with balloon sapphire 5.0 15 millimeters, and then we done a second recrossing, and then we did the final kissing balloon, and then we PCI the mid LAD with 3.020 millimeters, and then after that we post dilate interstent with overlapping stent with balloon sapphire 3.515, and then this is the result for left main LAD and LCX symmetry flow. And then we did the RCA with open with balloon score flex 3.015, and then we put stent 3.522, and then we evaluate with IFUS in the distal left main. We got 12.8 millimeter, and then on the proximal LAD we got 5.4, and the proximal LCX we got 5.7 millimeters, no edge dissections, stent well expand and well opposed. This is a proximal left main, MSA is 12.8, distal LAD is 4.7, distal LCX is 4.4. After 2 months follow-up at 10 September 2020, the patient, no chest pain, no complaint for daily activity, able to climb 4 stories building every day, and now he refused to do the FAR surgery. For take-home message, PCI might be the most appropriate choice for elderly CAD combined with severe bicuspid aortic stenosis who got recent ischemic stroke. Stents which need shorter dual antiplatelet therapy may be needed due to potential of high bleeding risk, and therefore IFUS guided PCI should be performed. Thank you.
Thank you, Dr. Wahyu. Now open for discussion. Any comment from Dr. Fujimoto?
Hi. I have a question. Why did you choose biofreedom stent only left main to LAD?
Oh, because I need in our cat lab we have only the long one is biofreedom, so no matter the who is the offender, it's just it's a matter of only the size we have for high bleeding risk stent.
Yes, that's
Dr. Wong from Taiwan, any comment?
Congratulations for your perfect and success work. I think this is a perfect PCI case, and but I think the post PCI is very long-term medication is very important for this patient. This is my comment.
Yeah.
Dr. Wahyu, have you heard of this 567 synonym? Actually, I mean the L6, 5, the LAD6, and the left wing at least 7.
Yeah.
Also, LAD is a little bit short of 6. So, do you think of actually get more higher pressure NC balloon to dilate the possible LAD more? Because I know it's calcified, but it can still be expandable.
Yeah. After because we already did for 3 hours, I think I just consult to my consultant. We all already tired, but I think 4 is already enough.
Understandable. Unfortunately, the old man refused any further surgery, particularly for his for his valve, which also can be a very important factor for his angina as well. Thank you very much, Dr. Wahyu. So we're coming to the next case, playing with fire, high-risk PCI in crucial SVG grafts using embolic protection devices by Dr. Shah from Malaysia. Dr. Shah?
Okay, good day, everyone. Okay, my name is Dr. Wan Faizal, Rahimi Shah from Malaysia. So I would like to share this very interesting case, which also is a very good teaching case for me, myself, as a clinical fellow here in my cardiac center. So the patient is a 53 years old male with background diabetes and hypertension. He had a bypass surgery previously in 2013. Now, I'm not so sure why, but the surgeon has implanted only venous grafts for this patient, 3 venous grafts, despite the patient's relatively young age. So he presented with a non-STEMI in another hospital, and then was referred to us for an urgent graft study and PCI. The baseline investigation shows the marked ST depression changes, and the echo shows the EF of 33%. However, clinically, he appears to be stable with clear lungs and no significant murmur. So I'll just skip the echo. Now, important is in terms of the graph study findings. I just summarize it up front. The graph shows severe native 3 vessel coronary artery disease, and we have CTO in all vessels, especially the mid part of each vessel. And when we did the graph, we only find 1 stump, but there are 2 other very diseased grafts. One is the saphenous venous graft to the OM, which shows a tight stenosis in the proximal part with long thrombus arising from the plaque. So this is, I want to emphasize, it's a very nasty plaque with also a time bomb sitting there in the graft. The other graft is a saphenous graft to the LAD, also disease with a disease in the proximal part. So just how to depict how serious the situation is to us dealing with this high-risk PCI, I'll just show you the native coronary arteries first. So here I can see all 3 vessels are heavily diseased and also having diffuse disease in the branches as well. So you can see here, we could not expect any support from the native coronary arteries at all. So the patient is dependent on one of these grafts. So I can see here, this is the venous graft to the OM. Notice that you don't just have a tight stenosis in the proximal part, but there's a thrombus, a long tail of thrombus rising from the plaque all the way up to near the distal part of the graft. The venous graft to the LAD also has significant disease in the proximal part. And again, as you can see, the previous grafts, all of these grafts has very diffuse and small outflow. The disease in the distal part is also heavily diseased. So you can see here, we are dealing not just a disease graft, there's also not much outflow after the disease. So looking at the algorithm for management of patient post-bypass. For arterial grafts, it seems to be much easier. But when we deal with venous grafts, obviously we have one of the things to consider whether to use an embolic protection device. Now, in many cases, many would prefer treating the native vessel instead of SVG. But in these kind of cases, as we can see, we cannot assess the native distal vessel at all. So we are stuck with trying to deal with the disease grafts from the initial part of the case. So this is just a summary of the embolic protection device. Obviously, as a young fellow, I do not know all of it. The one that I have is a spider effects. But I guess for senior consultants and consultants as well, probably they're more experienced using it. So the strategy was to intervene the SVGs as the intervention of the native vessels are near impossible, and also to use embolic protection device up front. We know the EF is impaired 33%, so we decided for at least a hemodynamic support with intra-aortic balloon pump. And when again dealing with disease graft, obviously we need to always think about additional strategies to minimize. So some of the additional extra things that we use is keeping the ACT high, using aggressive vasodilatation, direct stenting, slow and prolonged inflation. So all other steps which I listed there is that we can use to minimize this embolization. So the equipment specific for this case is the shiftless IBP via the left femoral access. We use a 6 French right femoral access with a JR 3.5 guiding catheter. We know that we have to deal with the very badly diseased venous graft to the OM, but this seems to be the more crucial part because of the underlying thrombus inside the graft. Well, as we added, the second seems to be relatively easier, so we plan to tackle it at the second. So here, I don't have the wire, the wiring of the vessel, but we use a gentle wiring. Now, this is a very tight stenosis. At the same time, there's a thrombus there. So we use a 2.5 times 15 millimeter semi-compliant balloon dilated only to 4 atmospheres just to allow the device to pass. That's it. It's not to dilate the vessel at all. And then, subsequently, we place the embolic protection device, a 4.0 millimeter times 190 centimeters spider effects in the distal part of the vessel, as you can see here, the deployment. Now, we are quite worried, again, whether we have dislodged that tail or thrombus. But thankfully, the intermittent angio show that the thrombus is still intact and still stuck to the proximal lesion. So at least for one, we did not dislodge the thrombus down to that very small OM vessel. We use direct stenting with a Resolute Onyx 3.0 times 22 millimeter at nominal pressure. One thing we did differently for this case, immediately after the stent, we did not even do a cine, but instead we go for immediate thrombus aspiration. Now, at this point of time, we did not know whether the thrombus is still stuck to the stent or maybe has gone into the embolic protection device. But we want the full removal of the thrombus either to the aspiration or to the device. So we went with the export advanced aspiration catheter. And thankfully, after that, as you can see the cine here, we see that beautiful graph, thrombus no longer thin, and at least the stent is well deployed. So we removed the EPD, and we saw large fragments of red thrombus in multiple strands. So we know for one, these are established thrombus. Now, after that, we did saw a bit the stent size a bit low. I know many people will not post dilate, but we decided to do a gentle post dilation with a 3.5 to 12 millimeter balloon. Otherwise, the result is good as we can show here after the 3.5 NC. So this is the part that, you know, one of those days when you deal with a high risk PCI, so you can breathe a sigh for relief after that you have settled this crucial part of the intervention. The LED part is relatively more straightforward. So we use the same device. Now the lumen is definitely larger. We could have used a large device, but we just recycle the same device due to cost consideration. And then subsequently we implant the stent at nominal pressure. Again, we use a 4.0 times 50 millimeter, slightly oversized the length. And then this is the final result, showing excellent graft patency with no distal embolization. And here, this is another view of the vessel. Now, the discussion point which I tried to point out was that ESC 2018 guideline has downgraded the use from a class 1 to class 2A. And I believe this downgrading of the indication was based on this meta-analysis by Paul, which have analyzed about 50,000 patients showing that routine APD use is not associated with reduction in events. Now, as a young fellow, obviously we don't have much experience, and over time we are seeing many of the time that embolic protection device not used. When we do not use it, we lose that skill. So this case has taught me that that skill should not be discarded. And as we know, the plaques of venous graft are very large, soft, and friable, with a lot of crystals and foam cells. And because they lack fibrous caps, they tend to embolize. They tend to have overlying thrombus. So operators, I believe, should evaluate the risk of a slow flow, no reflow in this kind of case, mainly because of the plaque composition, and the higher risk should mandate the use of embolic protection device. And the take-home message I've shown here is that this case shows appropriate use. Now, despite the lesser frequency used over time, it's a skill that must not be forgotten. And it's also a reminder to me as well. And at times, EPD can definitely be life-saving as demonstrated here. And in my thoughts, I feel that fellows should be trained well on at least one type of EPD in that they are competent to use. So I will end my presentation with these points.
Yeah, thank you, Dr. Shah. Now is open for discussion. Dr. Fujimoto, any comment on this case?
Yes. This case, region is not so long, so thrombus is not so much. So maybe direct stenting is good option. This case, yeah. But patency of SVD is not so good. So, do you have any plan to try CTO, negative CTO?
Yeah, that's a good question. Good, Dr. Fujimoto. Now, in this kind of case, we believe the distal vessels are very small. Yes. So, and there is a thrombus line there. So, we definitely believe if that thrombus has went down to the OM, patient could have suffered a cardiac arrest. The same thing that could happen in the LAD. These are very two crucial grafts which we think need to be intervened as soon as possible. So that's the reason why we use. If we opted to do that CTO, there's a chance that we might fail. And to top it of that, the patient has low EF. So this definitely incur a higher risk. Now, if the graft has degraded, meaning that it is disease, diffusely disease, is small, is a long lesions, then probably we will not have intervened. But as we can see here, the actual plaque itself is very focal in the proximal part. So we believe that we can probably stand this part and save the patient's life in much less risk as compared to doing the CTO intervention with less risk of success.
Dr. Wang, any comment?
I think it's very important to prevent thrombus migration to the native vessel, because the venous graft always larger than the native vessel. I think you can try any device to protect the thrombus migration. In our case lab, we just use filter wire, but sometimes it's not very well. From your presentation, maybe I can try your device next time. Thank you for your presentation.
Yeah, thank you. Actually, I would like to raise a question that actually looking at your angiogram, particularly on the native right coronary artery, now the graft is occluded. Do you have any plan for try the CTO of the right after you have successfully opened up the SVG on both LAD and the OM? I think can be an option for future. Another question is, as we know that actually the graft probably lasts for 10 years or a little bit more. By that time, he'll be about 55, maybe less than 60. If that graft failed again, what's your plan? CTO or transplant or mechanical heart?
Okay, yeah, that is also a very good question regarding the long-term plan. Now, the one thing missing information that we haven't obtained was why was no arterial grafts was used, because we know arterial graft, especially the lima, lasts much longer. So at this point of time, we don't have an answer for that, especially in this very young patient. So I think it's important that probably that we have to look whether the lima itself is a small size or whether it was not suitable for grafting. So in that kind of case, I don't have a clear-cut answer for that. Of course, over time, like you said, it's very true, the venous graft would have degraded. So I think it's important for us to closely follow up on this patient and look forward to the future. What are the options later on? Like I said before, we are missing a few information, so I'm not so sure what will the future hold for this patient. But again, it's a very good consideration.
Yeah, I think I will try to open up the RCA CTO at least.
Yeah.
At least he got one native option, because looking at the angiogram, I think it's quite doable. Do you agree, Dr. Fujimoto?
Yes.
Next presentation, left main bifurcation with cardiogenic shock by Dr. Thanawat Suesat from Thailand.
Good afternoon, everybody. My name is Thanawat Suesat from Khon Kaen, Thailand. I have no disclosure. My case was 82-year-old Thai male, female, presented with chest pain and underlying disease. She has a multiple underlying disease. At the presentations, blood pressure was below 80/50 millimeters. Vascular conscious. This is the EKG show the diffuse QVIF and S3 depressions from EKG. And this is a chest ratio myocardiomegally. She concludes that has a non-ST elevation MI with hypotension with the high Graylis score. Troponin T is significant rising. Echo show my LV dilatations. LV ejection fraction around 55%. My MR. This is the angiogram. The angiogram show diffuse left main disease with very tight and possible the osteocircumflex disease and moderate disease at the LAD circumflex and also RCA. So this patient had a very tight left main disease for the osteo, and I think Medina 101 and with the moderate disease at the LAD circumflex and RCA. What should I do? Ad hoc PCI, state PCI, cabbage, or medication treatment? If we calculated syntax score were certified with the high risk and also high risk with the Euro score and STS score, meaning that's high risk to surgery too. From the guidelines, prefer cabbage over PCIs. So I send patients to the surgery first. However, after patients talked with the surgeons, patient denied to surgeries, and at night, patient developed ventricular tachycardia and hypotension and was sent to the cath lab again. For hemodynamic support, I use the Protect PCI algorithm. If the score more than 2, prefer hemodynamic support when PCI. In the cath lab, I use the femoral approach with the 7 French guiding cycle. When I wiring the whisper wide from the left main to the LAD, patient developed ventricular tachycardia immediately. So I rapid dilatations at the LAD to left main with 2 balloons. And after that, wiring to the circumflex and P dilatation with the same balloon too. When I P dilate at the LAD, the plaque shift to the circumflex. And when I dilate the circumflex, the plaque shift to LAD, shift to another. So I decide to use kissing balloon for P dilatation with the trio from the LAD and 2 balloon to the circumflex. This is the results angiogram after IP dilatations. Okay, this is the improved flow to LAD and circumflex. I was watching from pullback from the circumflex to left main and also LAD to the left main. This is the IWAS information. We have the large left main with around 4 to 5 millimeters with the large plaque diffuse from the osteo left main to the to extending to the osteo circumflex, but just minimal disease at LAD osteo. So I decided to use the decay clutch technique because of the good clinical outcome in the recent data. So I used the irremoved stent first at the circumflex to the left main, and then clutch with the NC balloon from LAD and rewind at the proximal to the mid-strut. Then the first casings, then stent placed from left main to LAD, and rewind again. I use the cruces double lumen to make sure there's a wire inside the left main stent, and rewind at the mid-strut. Then open strut and final kissings with the NC balloon and the final part with the 5-0 balloon at the final. That is the results pullback after stent. I use the rule of the 5, 6, 7, 8 for the left main stent. This is the result. I think it's pretty good for achieve the luminal areas from the LAD circumflex and the left main with good position. The FFR to see the mid circumflex disease is what the 0.85, so we decide to treat with medical treatment. Patient can discharge after day 5, and he have no chest pain again, functional improve, and follow-up echo is this improvements after 3 months. This is the follow-up angiogram after 1 year. I think the pattern all of stent and everything looks good. So patient happy. This is a 1 year follow-up angiogram. For conclusions, left main bifurcation disease is more diffuse and angiographic may be inaccurate to assess the disease severity of both osteoblasts. So images is important for using the appropriate left main bifurcation strategy. If two strategy is needed, I think DK class is provide reliable from the data, the right and right option. Thank you for your attention.
Very good, excellent.
Yeah, excellent case. Yeah. Any comment, Dr. Jang?
I think the IVUS is very important in the left main case. Even for choosing the right size stent and as well as the opposing the stent strut to the vessel wall. I think with IVUS, we can treat left main very well.
Yeah, I think that's a really important comment. Any comment on that case, Dr. Fujimoto?
Yes, no, I think it's an excellent case, I think. DK crash is not popular in Japan. Maybe over 10 years ago, we performed DK crash, but long-term patency is not good for LCX. Yes. So we will recently perform a left main LAD stenting and KBT or LCX for DCB. Yes, I think it's better for such a case. But this case is excellent, I think. It's an emergent case.
Any comment, Dr. Wong?
On my personal opinion, this is a HP male here, 82 years old, and before arrival in your custody, but have two days delay. I think even in diagnosis angiography, I always use IBP in this cardiogenic shock condition. And despite his high CNS score, but I think this is very old patient. After the angiography, I will discuss with family and CVS team to decide which treatment is proper for this patient. From my opinion, PCI is a good choice for this patient. And from the, which technique is proper for this patient? I think a two-step technique is proper for this patient. DK cross or QRO, I think is suitable for this condition. This is my personal opinion. Thank you.
Thank you.
Can I raise a question to all the panelists and also presenter? Now there's a technique called restenting, actually using two stents simultaneously, one to the L8 and one to the L6 simultaneous, and then open up and then kissing the left main. Any one of you will consider that kind of possibility? Any from the panelists or from any of the presenter? There's a rather sort of old type technique in the past when you have two, very different size, the LAD, the SERT, both are so much smaller than the left main, then also the plug shifting one to the other, and you worry about recrossing the osteo of one of the others, then that is a possibility to use two stent, so-called the restent technique for this kind of case, particularly in this 82 years old man, because you are not expecting he will live for 100 years old because of his morbidity. He has COPD, he has stroke, things like that. So to save time and also actually do it quickly, 7 French guy, 8 French guy, and 2 stents simultaneously, one to the LAD and one to the SERT, and simultaneously open up, and that will do the job right away.
Yes.
Very simple.
If the main is bigger enough, then we can do that, making a new carina.
Yeah. Okay, but I think sometimes this kind of technique, because it's quick and might save situation like that. So I think that's another thing that we might remember. I'm old enough to see some of those. Yeah. So we're going for the last case. Can stand position be confirmed by conventional angiography by Dr. Hancock from Turkey?
So this is Dr. Emre Ancoğlu from Istanbul, Turkey. I would like to represent a case which can we discuss about can we confirm the stent opposition by a conventional angiography in provisional stenting. So in case we have a patient, a 53 years old patient admitted to our outpatient clinic with exertional angina pectoris for last 6 weeks. In addition, 1 week from the admission ago, he had a presyncope history. In past medical history, he has no diabetes, but he was an ex-smoker. So on ECG, we saw the previous anterior myocardial infarction findings, and we start the prescription aspirin with and beta blocker, then planned the elective coronary angiography. On ECG, you can see there is a precordial T waves negativity and the ventricular extrasystoles. And on echocardiography, we saw the apical hypokinesia, and the ejection fraction was 50. And we performed the coronary angiography, and there was total LAD occlusion at the distal portion, and the REJA and the JX was had minimal disease. In here, you can see the lesion, LAD lesion, and so we planned the provisional standing bifurcation lesion, and we choose the 6 French extra backup catheter. And our first attempt was very hard because the lesion it's hard to cross. So wiring and the balloon crossing were both difficult, and so we considered the balloon it was undilatable lesion. Then we used NC balloon to inflate the lesion, and we later 20 ATM. So and we picked the 3.0 stenting test stent, and you can see here. So in here we implanted the stent at 16 ATM. In here we still see there is a side the flow of the side branch were persisted, and you can see in the arrow in here. So we consider that our proximal stent it's not optimal, and we decide to inflate the balloon again. So with the stent balloon, we dilated it at 28 atm, and the perfusion of the side branch still persists in here. So we decided to make the pod proximal optimization, and after we use again 3.5 balloon at the 14 atm. So we saw the perfusion of the side branch was blocked, and we confirmed that our stent opposition was confirmed. You can see here the side branch flow is blocked. So we we don't have further attempt for the side branch because the patient symptoms and signs are relieved, and the TMUH flow at the side branch. As a result, we know the IVUS is very important to confirm the stent opposition or the expansion, but it's not available in the world, especially in our country. We can't do it every cases. So we consider that can we inject a small amount of contrast to confirm our inflation of the stent balloon, show us the expansion of the stent or the apposition. So we consider that this technique might decrease the unnecessary routine of the pods in some cases, especially with the small side branches, in which there's a usually small discrepancy between the proximal and distal main vessel. Thank you.
Okay, very good. I think it's a very interesting case, but maybe Dr. Fujimoto sensei, you can comment.
Before post-dilatation, you should insert some software to side branch, I think.
As a kind of protection, yeah.
Yes. It's not, with no IVUS, it's okay.
Yeah, you do your technique. I think you can make sure that your balloon size is enough, but sometimes the stent recoil immediately after your balloon, so you cannot judge the stent position is quite enough or not. But you can only say that your balloon size is enough to occlude the proximal portion. So I think that's the general opinion when the guy is doing IVUS. I think, thank you very much. I think it's time to close. Our time is already finished. Thank you for all the active discussion, and Dr. Chris Wong. Thank you.
Thank you.
Thank you very much. Bye-bye.
Bye-bye.
Thank you.